Hi everyone, it's right at 12 o'clock Central, so we'll go ahead and get started with today's webinar. My name is Larissa DeLuna with the American Heart Association, and I'd like to welcome you to the American Heart Association's Cardiac Boot Camp series. This is week 4 of our 7-week series. For a full list of upcoming webinars, visit heart.org/SWA quality. Before we get started, we'd like to go over a few housekeeping items. To avoid background noise, all lines have been placed on mute. For questions, you can unmute your line by pressing *6 or type in the Q&A section of WebEx. Attendance of this webinar will earn you 1 CE credit. Instructions to claim your credit will be sent after the webinar. Today's webinar will focus on STEMI Receiving Center best practices. We have 2 speakers, Karen Yates and Debbie Travis. Karen Yates is a nursing clinical coordinator at Methodist Mansfield Medical Center. In this role, she serves as a chest pain coordinator and EMS liaison. She has led the hospital to successful accreditation from the Joint Commission as a chest pain center. She also serves as the chair-elect for the Cardiac Committee of the North Central Texas Regional Advisory Council, also known as NCTRAC. This committee facilitates cardiac care, EMS transport guidelines, public education, and quality improvement initiatives for a 19-county region. She serves on the board of directors for NCTRAC. Karen is also active in the Mission Lifeline North Texas initiative and serves on the Governor's Advisory Council Cardiac Committee. Karen has over 35 years of experience in pre-hospital and hospital management of the acutely ill and injured patients. Karen's passion is education, and she teaches a wide variety of nursing and EMS courses. She holds a master's degree in nursing education and is certified by ANCC as a professional development educator. Debbie Travis is a quality coordinator for the chest pain program at Texas Health Arlington Memorial Hospital and Texas Health Heart and Vascular Hospital. And she has been in this position for almost 10 years. She has led both hospitals to successful accreditation from the Joint Commission for Chest Pain Centers. Debbie has her BSN and over 30 years of experience in the ICU, ER, and in her current position. She serves as a chair for the Cardiac Committee of the North Central Texas Regional Advisory Council for a year, and before that served as the chair-elect. Throughout Debbie's career, she has been devoted to the care and education of cardiac patients. At this time, I'll turn it over to Karen and Debbie. Just a reminder, you might want to unmute your line, *6. Can't hear you guys yet. *6 to unmute, and also check your phone itself to make sure it's not muted.
Okay, can you hear me now?
Yes, sure can.
Okay, got it now. I said, okay, we're already having technical issues and we just started. Okay, we're better nurses than we are IT people. My name is Debbie Travis, and I'm going to be talking about some of the guidelines.
Sorry, guys, we're having problems. Okay, go ahead.
Okay, first of all, for disclosures, either one of us have any financial disclosures or unlabeled, unapproved uses to disclose. So using the guidelines, if you're new to this position, the guidelines really determine how you're doing with your program. If you are not the person who enters your data into NCDR or get with the guidelines CAD, you need to get a log on and figure out how to use that so you can see what you need to improve on for your program. or you need to become best friends with your person who does do that information. Right now, the guidelines, the most current guidelines are the 2017 AHA ACC Clinical Performance and Quality Measures, and you all can read that. I don't need to read that to you. At the bottom is a link so you can get to those guidelines, and you need to become familiar with those because those really determine what you need to be looking at for your program. I'm not going to go over all the guidelines, but between Karen and I, we both had some that we know caused some issues for our programs, and probably since we talk to a lot of people, we know that they cause problems for a lot of the programs. So the first one is NCDR has changed this year, and one of the things that they're looking at is more the first medical contact to device time instead of the door to first device. So that makes a difference because now your EMS time counts towards that first medical contact time. So now you have to make sure that you get the run sheets because the people who do your abstraction will need that for that first medical contact time. So for EMS arrival, less than 120 minutes if they've been transported. If the transport time is greater than 45 minutes. First medical contact to device is less than 90 minutes. And if they come by private vehicle, that will be the time that they arrive in your emergency department or your door time. And the first medical contact will be the earliest time in the chart.
So I think one thing, this is Karen, one thing just to add real quickly on top of what Debbie just said, is really making sure that you or somebody in your facility is communicating with EMS the importance of not spending a lot of time on scene. We had a great STEMI case the other day at the hospital. EMS did everything right, and we actually gave them kudos for it, and our door-to-balloon time was great. And it was exactly 90 minutes from first medical contact to balloon time. So that's one of the things that I try to circle back with the EMS crew and go, hey, you guys did everything right, but really pay attention to, a minute here and 3 minutes here on scene when, in fact, they could already be en route to the hospital. All of those add up to important minutes for the patient as well as for all of us.
And even more importantly, if they know that there's some items that they're going to have to be on scene a little bit longer, they need to let the hospital know as soon as they get that first EKG, because even if they're not transporting the patient, if they let you know beforehand and you're getting the cath lab ready, then obviously the patient may either be able to go straight to the cath lab or have a very short stay in the emergency department. And those minutes matter. The measure here is the percentage of patients that were hospitalized with non-STEMI who have a risk stratification score. New to NCDR, this time there is a measure that talks about, for your non-STEMIs or your in-STEMIs, that if there's a high risk for them, if their risk stratification is high, they need to go to the cath lab sooner rather than later. Previously, that didn't really matter, and where this really comes into play is those patients that come in on Friday that the cardiologists don't particularly want to come in on Saturday or Sunday to do it, or the cath lab doesn't want to pay their overtime personnel to come in, then they are not getting to the cath lab in a timely manner. And so you'll actually kind of be dinged for that. That's new this year. So the risk stratification score needs to be documented during their hospitalization either by the emergency department or by your cardiologist or interventionalist or whoever admitted the patient. Any risk stratification score is acceptable, so your TIMI score, your heart score, there's all kinds of them.
GRACE score.
GRACE score. Fibrinolytic therapy for primary perfusion with the time from hospital arrival to the fibrinolytics being given is less than 30 minutes. Although this is a measure, I think most of the hospitals now, very few of us give them, even with the transfer. There's some places that if you're transferring all your patients, and obviously that's more important for you. I will tell you that my cardiologists are not fans of this. They would prefer not to give the lytics. So if you are for a transferring facility and you transfer all your patients out because you don't do the cath lab at your hospitals, you need to find out from your receiving hospital what those cardiologists want done, because I know this is a guideline, but I know that mine don't particularly like to have the fibrolytics given.
Yeah, and mine are the same at my facility, and so we do get transfers like many of us, either in the room or on the line. And so it's really talking with your cardiologist, talking with your transferring facility to make sure that they understand. Don't automatically do it and then call and give reports stating that, because just like Debbie's docs, some of which we share, they actually don't prefer that. We have done it in a couple cases where patients that normally would be coming in by helicopter, the helicopter can't fly because of weather conditions, so now you have a much longer ground transport time. When that's the situation, we've just consulted with the receiving cardiologist, and in those cases, they have gone ahead and had them administer the lytics prior to transfer or during transfer.
Someone has sent a question, and they said, is the TIMI acceptable for NCDR? I thought it was heart score. Actually, it's any risk stratification score. If you use the GRACE or the TIMI, they actually have to put the number in. But for the others, it's just yes that a risk stratification score was completed. So on this slide, you may have to blow it up to see it a little more, but specifically what they're talking about is the resuscitation from out-of-hospital cardiac arrest and whose EKG does not show STEMI, who should go to the cath lab and who should not. And in the black box is the things that we really wanted to point out to everyone. I'm not sure if I can even read them all in here. So unwitnessed arrest, initial rhythm was not VFib, no bystander CPR, greater than 30 minutes to achieve ROSC. These are all reasons to consider not taking the patient to the cath lab. Obviously, that's up to the cardiologist and the ER physician to discuss prior to the final decision being made. But there are reasons not to take the patient to the cath lab. So we just wanted to point that out. This was a percentage of patients hospitalized with an AMI with documentation in the hospital record that the LVEF is evaluated during hospitalization or is planned for after discharge. Where you get into this measure not being completed, let's say a patient was just in the hospital a couple weeks ago for his heart failure, and he had either a cath or an echo done, and his EF was already less than 40%. And now the physician comes in 2 weeks later, he's had a heart attack, and the cardiologist will be like, well, I don't want to, we're going to treat him medically, so I don't need to take him to the cath lab. And I don't want to repeat the echo because I already know his EF is less than 40%, so it's not going to be better, especially right after an acute MI. So then they'll not want to do the echo. The important thing is you need to just convince them that in the chart they need to put that they're going to evaluate the EF as an outpatient. That's all, and then that covers that measure. So if they're not going to do the cath or the echo or the TEE, then they need to just put that they're going to do it as an outpatient. And most of the cardiologists will do it in their office. Usually they'll wait for a month or so and give the patient a chance for the heart to rest really well, because then they think that they're going to get a better EF that will be more what it truly will be later for the patient. High-dose statins. Okay, this is another one that may get your cardiologist in a dither. High-dose statins are recommended for all patients. Now, on here, from our most recent guidelines, it says over the age of 75, you can use a moderate-intensity statin rather than a high-intensity statin. But last week, there were new guidelines that were just released on cholesterol for stroke and AMI patients. And it specifically says that high-intensity statins were recommended even for patients over the age of 75, especially if they've already been on the high-intensity statins, and so long as they can tolerate it. Obviously, if they can't tolerate it, all you have to do is put a reason, patient doesn't tolerate high-intensity statins, and that's it, and then you're okay on that measure again. So the important thing is the physicians just have to learn what the guidelines are, and if it's not appropriate for that patient, to put it in the chart, and then you kind of get your grace period for that. Cardiac rehab referrals. Again, this can be a struggle for a lot of facilities. This is especially true on those patients who come in on Friday and get discharged on Sunday, or come in on Friday and get discharged first thing Monday morning. The way we have gotten around that for our staff is that they have a handout that they can give to the patient that tells them about cardiac rehab and gives them the phone number to call if they have any questions. And so long as that's put in the chart that they receive that information, then we're good on that. But it specifically for NCDR, that has to be done prior to the patient leaving the hospital. So even if they don't hand out that hand out that pamphlet that we have to the patient, and if it doesn't get charted, or they get the pamphlet and it doesn't get charted, then our cardiac rehab does call them, but it's going to be a miss because it specifically says that this has to be done prior to them leaving the hospital for NCDR. So cardiac rehab is not difficult. I mean, all of our patients get a cardiac rehab referral. The problem is these other cases where they happen to fall in that little gray area, and then they will get missed. Also, some of the nurses felt like if they were going to a nursing home or a skilled nursing facility, that they didn't need a cardiac rehab referral, and that's not true. They need the referral, and even if they do the referral and they say they're not a candidate because they've had a stroke in the past and they wouldn't be able to participate, then that's fine. There just has to be a reason documented. So once again, same thing that I've said for every one of these, so long as there's a reason documented, then they won't be a miss and you'll be okay on those items. You have to participate in a national or regional AMI registry, whether that's NCDR, Get With the Guidelines CAD. There's a ton of registries for MIs. These are the two most common ones, I think, that I know of. And I know them because those are the ones we use. There has to be verification or rate of reliability done. You need to be familiar, like I said earlier, how your abstractor interprets the rules. The rules are the same, and they're supposed to be the same for everyone, but the data dictionary still can be interpreted differently, and that can make a difference. And if so, you need to find out what those are. What if you use an outside abstractor company? You still need to be able to make sure that you know who that person is so that you can get in touch with them if you go through if you look at your data and you don't think that it's correct, you need to be able to say, hey, this isn't right, and you need to know who to go to. If you don't know who to go to, then you can't. And they're looking at the charts, and you're in the chart probably daily once you identify a STEMI or a non-STEMI patient. So you may have already found it somewhere, and they are looking at it after the fact, and they maybe don't find it like you do.
Let me speak to something real quickly, Debbie. So the organization that I work for, we do use an outside vendor to do all of our chart abstraction. And so what we had them start to do, instead of getting, this huge report periodically, we have them send us a weekly report now, so we know if they're missing something or they identify a problem in a chart. And so as the chest pain coordinator or as anybody else that might be trying to help me, it's much less labor intensive to do a week's worth of data versus, a month or 3 months or whatever it happens to be when they send it to us. So you may want to take that into consideration as well.
Yes, for me, I actually have a login for NCDR. I do not for Get With The Guidelines CAD. Our NCDR data is pushed over to Get With The Guidelines CAD. So I have a login for NCDR so I can look up any time and see how things are going. Someone has said that the guide link is not working. Oh, yeah, and so if you just, at the top we have the title. If you just,
she shared the one.
Yeah.
Okay.
So, and if you don't, then at the top where the title was, you can look it up there. Is there anything else? And
Okay.
now I'm turning it over to Sharon.
She's going to turn it over to me now. But as you can probably tell, we do a little bit of tag teaming on this anyway. Debbie and I have worked together, even though we're at two separate organizations, we've worked together for a very long time. So this is the current, the newest, latest, and greatest Mission Lifeline STEMI recognition measures. And I want to point out a couple things. You'll see that quite a few things that there hasn't been a change to it, so you can see that noted on the right-hand side. But I do want to point out a couple things in regards to aspirin on arrival, as well,
Smoking
smoking cessation. Those are things that all of us have focused on for a really long time, probably even before we were accredited as chest pain hospitals in some cases. And so those are still reporting measures, but they're not part of the criteria that you have to meet. So, don't let it drop off your radar screen completely, but it's just not something that for this that they're going to focus on. Now, what is new is arrival of the patient to a 12-lead time. And I'm sure for many of you on the line, this is something that you probably look at. You may track it. For us, it's been one of our Joint Commission reporting measures that we've utilized. And actually, we were reaccredited last summer by Joint Commission as a chest pain center, and we actually dropped ours down to 7 minutes. And I was really, really concerned about that. Our goal at my facility is 80% or greater within 7 minutes. And we actually, sometimes we struggle to meet that goal, but our numbers aren't any worse than when it was 10 minutes. So it's amazing that when you do move the bar, they actually do try to meet that as a criteria. So just something to think about. If you're doing a really good job in 10 minutes, then maybe consider dropping it down just a little bit. And then another thing that is new is the cardiac rehab referral, as you can see down there in the bottom right-hand corner. Your non-STEMI recognition measures, you can see those listed here. I'm not going to read those to you, but you can see just quickly, it's your ACE and ARB at discharge, your cardiac rehab, your dual antiplatelet therapy, the LV function, smoking cessation, you can see is listed there. And then, of course, the more that we all collaborate, so on this slide, I think it's just really showing the partnership of, it's not just the receiving center, it's not just the referral center and the receiving center, if that's the situation you're dealing with, it's EMS, and obviously I feel passionately about that because I'm an EMS liaison also, but, the hospital can be doing everything right, but if EMS isn't, then, we have a challenge on our hands. Likewise, if EMS is doing everything wonderfully, but they don't have confidence in what the hospital is doing, then clearly there's a break in the system somewhere. So it really is a collaboration. I know that's something that we've worked really hard on in our area, in the Dallas-Fort Worth area. It's really improved communication and collaboration amongst all of our partners. And, because it really comes down to it's all about the patient. And, so if we want to achieve best practice for the patient, we all have to get on the same page and work together. Let's talk for a few minutes about order sets. And, as it points out here, order sets really are designed to make everyone's life easier. I know sometimes you have to work on making sure that they're following the order set, that they're not going, some of your physicians or other practitioners aren't going rogue and doing something differently or separate away from your order set. But, if they're done correctly, they're done well, the physicians are educated in them, the goal is really to take the guesswork out of it and make it easier for them to be able to order the appropriate things for their patient. They have to be reviewed frequently, and, of course, I'm assuming that many of you on the line are part of a larger health system. You're not a standalone hospital just onto yourself. And so, of course, when you're in a system, and then the larger the system, you have to review it not just at your own facility level, but it has to be, reviewed for your entire system for consistency. And so sometimes that can be a challenge because obviously the more layers you add to things and the more cooks there are in the kitchen, then it just becomes, it tends to slow things down. But you've got to make sure you stay on top of them so that you don't have a surprise, which usually tends to come up during a site visit, and you have a surveyor that's very, very familiar with best practice, and they're looking at, a chest pain order set or a post-CPR order set or something, and then that suddenly you realize that it has not been updated with the most current information.
And I will say that this is one of the things that Joint Commission is really harping on now. So I guarantee when they come in, they're going to ask to see your order set, if that's who you're being certified through, that they're going to ask to see your order set, and they will recognize if a physician has not used the order set. Mm-hmm. And then you're going to be stuck trying to explain that or trying to figure out how often your order set is used.
Something just that came to mind to me, just to kind of tag on sort of what Debbie just said, is those of you that whatever survey you go through, one thing I found that works really well for me is I will have somebody attached to my survey team that their sole job is to navigate the chart. Because you may be very proficient in maybe the inpatient navigation, but not so much on the emergency department end or vice versa. So we found that normally what we do is tap into one of our resource team nurses or something that works emergency department as well as critical care, and so they're really good at where to find different pieces of information in a patient's chart, and it takes the stress off of you as the chest pain coordinator or the quality director or whoever you happen to be, not having to worry about that one component. So I just wanted to throw that out there because we've done that the last two surveys, and it has made life so much easier.
We actually have someone from IT come. Yeah. So
I think we're all about what we can do to make our lives easier. So let's talk about physician leadership and, how do you get the right leadership? How do you get physician buy-in? How do you get all of that? I've been in my position at Methodist Mansfield for almost 10 years now. Been with Methodist Health System for many years, but when I initially came into that position, one, I had no cardiology background, so that was kind of a new thing for me, was to figure out what all the little squiggly lines meant on these EKGs because I had more of a trauma background. And I didn't really know, I didn't know any of the cardiologists at the facility. I did know some of the ER physicians, so that made that a little bit easier. So I know that when I was first looking for that physician champion, which also I needed to be the chest pain medical director, I actually gravitated to the ED medical director because I knew him. And, it doesn't matter if your medical director is an emergency department physician, a cardiologist, it just needs to be somebody that's very familiar with, the process of taking care of that patient population. So, identifying that champion or group of champions, is going to be really important. But then how do you get buy-in, at a bigger level? So, as it points out in this first bullet point, it's multiple specialties. It's not just the emergency department. It's obviously cardiology, not interventionalist as well as non-interventional cardiology. If you're using a hospitalist group, then you need to make sure you engage the hospitalist group because in my facility, they tend to admit about 95% of the patients, and then cardiology or surgery or whomever is the consulting physician. Or it's going to be your internal medicine group if you don't use a hospitalist practice. So you have to, when you're building a committee or you're wanting to revamp your chest pain or your STEMI committee, look at, do you have all the appropriate physicians at the table? And, not only are they there, they're not just showing up to the meeting. You need physicians that are engaged and are actually bringing something to the table and then are taking information back to their individual physicians in their group. So they have to have that right mindset. They have to buy into the process, because if they don't care, if they're there just because their medical director told them they had to be there, in some cases they can create more problems than really help with any solutions. So that can be a struggle, I think, for some people. So it really is, in the emergent end of things, for example, with a STEMI patient, it really is the partnership between the emergency department and cardiology. So in this case, because we're talking physicians, you have to find, the ED physician and the cardiologist that, that can work really well together, that are on the same page with what they're trying to accomplish for patients. And, by having those champion physicians, then it helps that they can then serve to help bring on, other physicians on board. Some of the ones that may be the naysayers or the stragglers or the ones that don't want to follow order stats and kind of tend to go rogue with you. And they obviously have to be familiar with, the order stats, what is evidence-based practice, the guidelines, all of that.
I wanted to add one thing about that first bullet point on the ED, cardiologist, the hospitalist, internal medicine. Before, when I was talking about all the guidelines and stuff, I said so long as they chart why they don't do specific guidelines, then that kind of grays out the area when they're doing it, and so it doesn't count against you as a miss. You need to find out which note your person who's abstracting is using, because if your cardiologist has put that the patient had type 2 MI, and the hospitalist just calls it a non-STEMI, for us, specifically, what coding will use is what the hospitalist uses in his discharge summary. Even though the cardiologist should have more say on that, I feel like, but I don't get to make these rules. So then it would still be coded as a non-STEMI, and then you would have all of those items. And a type 2 MI obviously doesn't need all the same bullet points that a non-STEMI patient needs. So you need to find out which notes they're using, and if not, you need to get the hospitalist to agree with what the cardiologist has said.
Well, and to add even on that, I've had situations occasionally with a hospitalist where, the patient gets admitted under them because the patient was a STEMI and went right to the cath lab, or was an emergent non-STEMI that went right to the cath lab, and so that's their admitting diagnosis to the hospital. We'll keep it easy, we'll say STEMI, but then in fact it turns out not to be a STEMI. The patient had a clean heart cath, but yet that diagnosis of STEMI manages to keep getting attached to every note during the hospitalization, and in some cases I've seen it pop up on a discharge summary, and so then I have to circle back with their medical director and say, no, they need to go back and read the summary of the cath lab report, and they'll see that the STEMI was ruled out. It was a Takotsubo, or it was pericarditis, or whatever the diagnosis ended up being, because obviously you don't want a patient that now in their medical record forever identifies that they had an event that they didn't even have. So that's just kind of an aside to something to watch for.
Just something else for you to worry about.
Something else to have to worry about. All right, so let's talk a little bit about emergency department to cardiology communication, and, how does that work? How should it work? What are best practices? All of that. So I'm assuming that if you're a STEMI receiving center, you obviously have a process in place for how do you activate your cath lab, and of course the process may be very different depending on if the patient's coming by transfer or coming by EMS versus they're a walk-in patient. Of course, the walk-ins always tend to walk in at the worst possible time, and they catch everybody off guard, and you hope that they got the EKG right away, and you hope that it's not crazy busy in the cath lab, when those patients present, but that just is what it is. But if you don't have a clearly defined written process for that, I would certainly encourage you to have that and make sure that everybody understands that process. Certainly for most of us, if not all of us, we are used to EMS transmitting their EKGs. One of the things that we did early on in my facility, and it's very different from location to location, even within my own health system, is we don't have EMS transmit every single EKG to us. And the reason we do that, we don't use teletext in the emergency department, which would be where those EKGs are coming. So what we didn't want were for the really important EKGs to kind of get lost in the middle of all the normal sinus rhythms or, sinus tach EKG or something. So, again, speaking just to my facility, EMS only transmits EKGs, either a critical patient, a STEMI, a patient they think might be a STEMI, those types of things. But that's going to be driven by what your local process is. One thing that can be a challenge is if you get or have maybe an old school cardiologist that doesn't buy into the EMS activation of the cath lab. That is certainly best practice. It is what we do certainly in the Dallas-Fort Worth area, that at my facility, and I think, most everybody else's up here, if EMS calls with or without an EKG and they say they have a STEMI patient, we just activate the cath lab, and it doesn't matter if it's 3 o'clock in the afternoon on a Thursday or if it's 3 a.m. on Easter Sunday morning, which we just had actually last weekend. We activate the cath lab. The EKG obviously helps with things. It helps, give confidence probably to the cardiologist and the ED physician that that's in fact what they're dealing with, but there really shouldn't be a delay in that. So if you're struggling with that, feel free to reach out to Debbie or I. We'll be more than happy to help you with that.
Along those same guidelines now, those cardiologists who have not wanted activation prior, their first medical contact time is going to be way out there, and they're going to start falling out on that. Yeah. And they're not going to understand why they're falling out all of a sudden. It's because their first medical contact time is not when they come into the emergency room if they're seen by EMS. It's from the time EMS is at the patient's side. Mm-hmm. So if they've waited 30 minutes before the patient got to the hospital before they call, guess what? It's going to be hard-pressed to make those times.
Which ties right into that next bullet point. Occasionally you see these cardiologists that, I want to come to the ER and I'll evaluate them first. I want to talk to the patient and I want to look at 47 EKGs that the ED and EMS have done and everything, and then we'll decide what to do. That is not best practice. I tell them that is not what we do in our facility. For my individual place, we have, kind of our core group of cardiologists that are there all the time, and then we have one or two that occasionally will take calls to maintain their privileges, and that sometimes can be where your challenges are because they tend to not be always as familiar with what the day-to-day practices are. One thing that does rear its head for us is, what do you do if, let's say, EMS calls and they activate the cath lab, you've done that process, you've called your on-call interventional cardiologist, they're coming to the emergency department or to the cath lab, you've got your team mobilized. Now the patient gets there, but you find out, the patient already has a cardiologist, and they have a cardiologist that practices at your facility. Well, now what do you do? So how we handled it at my place, because I am in a relatively, smaller community. We have several cardiology groups in the area. So what we do as a courtesy is we've already activated Dr. X because they're on call for intervention. But we go ahead and call Dr. Y and we say, just for your information, the patient is here, they're having a STEMI. Dr. X is here and is more than ready and willing to take them to the cath lab, but what would you like to do? Most of the time they will defer to allowing the on-call physician to go ahead and take and perform that initial case. In some cases, they're in the building and then they say, I'm right down the hall, I'll go ahead and come and take care of it myself. But just something to think about so you don't have a cardiologist screaming at you later that, nobody called me and told me my patient was having a STEMI and I could have come in and taken care of that situation.
Yeah, the difference at my hospital is it was decided that we would have one call and we would call a STEMI on-call doctor, and it didn't matter if they had a different cardiologist. Then what that person does, if it's a weekend or at night, they'll tell them to call the patient's cardiologist in the morning and let them know, and then they take over the care of the patient from that point. But they do not come in to do the cath.
And that's actually what I prefer, and that's what I tried to sell at our place, but sometimes to appease physicians, you have to, again, 99% of the time, it's the on-call physician that ends up doing the case, but we still at least make that courtesy call. And then the other question, that we get asked sometimes, and this has been a discussion at many meetings that Debbie and I have been at, is do you track overactivation of the cath lab? I do track it, so I track any time the cath lab was activated, but then the patient didn't go to the lab. Whether that's, an EMS activation, a physician activation, a transfer activation, whoever that is, I don't make a big issue of it. I don't circle back to EMS and say, hey, you activated the cath lab when you shouldn't, unless I feel like there's really an education need, and then I do circle back usually with your EMS coordinator or EMS chief to see if we can facilitate some kind of education. But that's such a rarity. Honestly, most of my overactivations are usually a transferring facility that activates when, in fact, it is not, in fact, a STEMI.
And you'll find sometimes you won't even know about those. I found one just a couple weeks ago that I had no idea that we had activated the cath lab. I'm reading the chart for some other reason, and lo and behold, I see that they canceled the cath lab activation. I was totally unaware of it. So sometimes you won't even know about those.
Okay, so let's talk about multidisciplinary meetings. This is something that we were asked to make sure to hit on. And so when you're either setting up a STEMI steering team, chest pain team, whatever you want to call it, or, you're just evaluating what you already have, I think we all need to sit back and really kind of look around the table or look around the roster of that sign-in sheet and go, do I have all the right players at the table? Because I think sometimes, you may leave somebody out and not even realize that, gosh, we should have been including them all along, or maybe somebody's position changed, and, so now you have a department that's not being allowed a space at the table simply because we didn't add, whoever the replacement person was onto our meeting invite or something. So, the things that Debbie and I came up with as, really these are sort of the have-to-have or strongly recommended. Obviously, the chest pain coordinator and the chest pain medical director, that's a given. If you're not including EMS, I would really, really encourage you to involve EMS. Sometimes that can be a challenge for them to get there. The consistent EMS representation that I have is actually from one of our flight programs, but they also have a ground 911 division. So they're able to come in and speak to kind of the ground ambulance as well as aero medical and kind of what's current in EMS and all that, so that works well. If you can get hospital administration at your meetings, I think that's a best practice. I definitely found that when hospital administration, whether that was our hospital president or our CNO, when they started popping in on meetings, and they're not always there 100% of the time, but when they started showing up at meetings, so did a whole lot of other people that hadn't been showing up or had not been consistent about it. So that might be something to think of. You obviously have to have your emergency department leadership, whether that's a clinical coordinator, a manager, a director, whomever the emergency department decides is the most appropriate person. I would certainly have an emergency department physician. I would also include, if you could get an emergency department nurse there, I think that would be really helpful because they can speak to what their own processes are from the nursing and physician end of things. Same thing in regards to cardiology, cardiologist, which in many cases is going to be your medical director. Cath lab staff, I found that getting them to early morning meetings can be a challenge because they tend to be in the middle of cases. But, try to get somebody from that area that can speak specifically and very specifically from in-depth knowledge of cath lab practices. I think that's helpful. Obviously, your people like critical care, your cardiac telemetry units, all the same thing. You need some leadership folks that can be there. Case management, because they're the ones, looking at the patient after kind of that acute phase of things, and, particularly if the patient's going to require placement at some facility or, home health, things like that, your case management people are important. If you have cardiac rehab at your facility, which I currently do not, then certainly representation from your cardiac rehab people would be important, just like your quality department. You would want to have them involved. I would have a hospitalist at the table, again, if you're in that model of a hospitalist or critical care intensivist, internal medicine, whomever you deem appropriate. And then those ad hoc people that you may not need at every single meeting, but I would certainly make sure you're bringing them to the table when appropriate. So those are your pharmacy reps, your lab, respiratory therapy, those types of people. We've also included admitting in ours. They don't always come to every meeting, but I make sure that admitting is well aware if we're talking about, anything that impacts them, that they are coming, that they know that they need to send representation to that meeting for obvious reasons. And hold tight, the computer is locking up.
You want me to try?
Yes, please, because I've already hit it twice. Okay. Thank you. So in your meetings, I think something that's really important that I think many committees sometimes struggle with is those meetings have to be meaningful. That's why people don't attend, or that's why they're not engaged during a meeting, is if they feel like they're just having a meeting just to meet. I know that personally nothing drives me more crazy than to go to a meeting, whether it's early in the morning or even more so if it's off campus and you have to leave and go somewhere, and then there's really not a reason to have a meeting. It's something that could have been canceled. So if you really don't have anything to report, then everybody's busy, honor their time, cancel the meeting. But make it as meaningful as possible. For us, it's definitely a time to review our data. Where are we, so there's no surprises to anybody in the group. Certainly review your process improvement initiatives. So at every one of our chest pain steering committee meetings, we do go over what are the results for the current 4 PI initiatives that we track and trace for Joint Commission for our accreditation. We go over those. We talk about anything that we may be working on. If we have one of our PI measures that we're still struggling with a little bit, what are we doing to try to improve that? So what are the opportunities for improvement, whether it's related to PI measures or other things, that pertain to your committee. Make sure that everybody feels like they're valued and that they bring important information to the table, because, it kind of goes back to what we said about EMS and the hospital. We're all in partnership together. So, if admitting can't figure out how to get the patient admitted in a timely manner, it doesn't matter that the cath lab's ready. They can't perform a procedure without an armband and the patient being in the computer. So making sure that everybody understands what their role is and that their role really is important to management of that patient. Try to allow time at the end of the meeting, 5 minutes, 10 minutes for just kind of updates from departments, roundtable discussions. Sometimes that's when other issues may come out that you didn't even know was an issue. You didn't even know that you needed to put it on your agenda. So try to build in some time for that. Personally, I always try to provide some kind of an education update. So, hey, here's my system. We have an annual cardiology conference. I know Debbie's system does the same thing. So here's here's the date of our conference coming up, or here's some other things in the marketplace that we're aware of, just so people know what's out there that they can attend for continuing education or just for the knowledge. I also, at my committee, kind of do an update on what's going on within our region. So within the RAC, what are we talking about at the RAC Cardiac Committee, which is a lot of the same stuff without the specific data pertaining to one hospital, a lot of the same kind of things. I also talk about if we've had a GTAC meeting. If you're not familiar with GTAC, you can look that up. That is the Governor's Committee. We meet 4 times a year, and so I try to make sure that they understand what's going on at a larger level. What is the state talking about? What's important, to that committee? One of our big areas of discussion has been public education, the importance of calling 911. That's a huge problem that I think all of us wish that we could figure out the solution to. We also talk about the need for a statewide registry for resuscitation, a CARES registry or something similar. So again, just so they understand, because, a lot of your people that participate in this committee, they don't go to those kind of meetings, so that they understand or have a sense of what's going on.
Also, for my meetings, I send out my agenda, my data, all that stuff, like the day or 2 days before the meeting, so that they can look over it, and if they have any questions, then they can bring that to the meeting. So I think that that's helpful, because then they see what the agenda is, too.
Okay, so we're getting kind of close to wrapping up, because, we want to honor your time, and probably some people haven't had lunch. But Debbie and I did want to talk a little bit about transferring facilities, freestanding emergency departments in particular. I know for us in our marketplace, just in my hospital, my community is roughly about 75,000 people. So we have my hospital, we have 3 freestanding emergency departments inside the city limits, but within probably a stone's throw or an easy drive, we have about 18 of these facilities that have popped up in our immediate service area, and it's probably about the same for you, I would suspect. So it's really important. I think the transferring facilities, and I'm sure some of you on the line are representing, a facility that doesn't handle STEMIs, and you do transfer at your facilities or your STEMI patients. So I think that the closer that your transferring and your receiving facilities can work together. We brought one hospital on board several years ago, and they were great. Everything that they did step by step, they wanted our input on. They sent us their processes, their protocols, their orders. Do you like the way all this looks? We've done some drills with them, on not just emergency department transfer of STEMIs, but, if it was an inpatient, what do they do to be able to move their inpatient quickly? So again, I think it goes back just to that collaboration that we've kind of talked about. Remember that if it is a transfer, wherever it is that they're coming from, whether it's another hospital or a freestanding emergency department, we do have a little bit longer on the first medical contact to balloon, so you do have 120 minutes with that. With the one facility that we work with quite a bit, separate one hospital facility, it was a little bit of a challenge at first, but the more we worked together, we shared information. Instead of being at 120 or sometimes greater minutes, now they're down to first medical contact for them to our balloon. Is now 90 minutes and less. So we'll have some cases they're 80, 85 minutes. And that means that they've done everything right on their end. They're identifying that patient quickly and activating our process, and they get a helicopter on the ground as quickly as they can and just get the patient out of there. Another thing to consider, really is that appropriate mode of transportation. So, how long is it going to take from transferring facility to receiving facility, and what is the most appropriate means of transport? Is it aeromedical or is it a ground ambulance? The ground ambulance can present a whole different set of problems, because I know for some of us in this area, not so much with hospitals, but with the freestanding emergency departments, many of them contract with a non-emergency transferring service, and in some cases that may or may not be based at their facility. And I know with some of them, when I talk to them about this, they say, well, I have an ambulance based at my facility. Well, the ambulance may be based at the facility, but it doesn't mean that it's necessarily there 24/7, because that ambulance is running other transfer calls, within their service area. So what we've really tried to encourage in this area is for those facilities to collaborate with 911, even though 911 normally does not respond into any type of a hospital type of setting. But I know in Mansfield, our fire department has absolutely no problem responding to a freestanding emergency department if it's an emergency transfer. So if they have, it's a STEMI, it's a stroke, it's a trauma, anything big like that, a really critical patient, they will go ahead and respond in and move that patient out of that facility. And I'm sure Debbie's the same.
Mine too, yeah.
Actually, in Debbie's city, it's a little bit easier, because their 911 services also has the contract for transfer. So that makes it, I think, a little bit easier. But I think just the more of those communications that can take place, only helps streamline the process. And don't be afraid to reach out and say, hey, can we do a drill or something to help as well? What you practice in advance always helps later down the road. Another thing to point out would be follow-up. And so this follow-up, I know this follow-up is important not only to a transferring facility, but also to an EMS agency. So I put a couple examples in here of the types of follow-ups that I do. I just took names of places off of it. And so I'll do a template like this that will show, in this case, on this slide, it's an EMS activation. So you can see their time. What time did the 911 call come in? What time did they establish patient contact? How quickly did they do an EKG, activate the cath lab? what time they arrived in the emergency department, and then you can also see the cath lab times. So I will break down for them, the door to balloon time separate from the EMS or the first medical contact to balloon time, and then what was the occlusion and what was the intervention that was done for the patient, along with the images. If they've transmitted a 12-lead EKG, I go ahead and include that 12-lead EKG. If you're not doing this is not as labor-intensive as you might think it would be. I honestly just go to the cath lab with my phone. I have them pull up images. I don't figure out how to download images and get them and everything from the lab, from their documentation system. I just pull it up. I have them pull it up. I take a picture of it with my phone, making sure that I don't show patient identifiers. I email it to myself and then just crop it a little bit and insert it into a slide like this. The other thing is if you have cases, good or bad, share these same images. The staff in the emergency department like to see it. The ED physician likes to see it. They want to know how they did as well. So it helps to show, I think the good and the bad and where the opportunities for improvement can be. Mm-hmm. Anything else you want to say? Okay.
Yeah.
And we found a little while ago, so this was our video that we were going to end with, but what we found is that the audio will not play for you. So this will be up to you. If you want to have a couple minutes of laughter over lunch or at the end of a long day, go into YouTube and just Google interventional cardiologist versus ER physician. It's something that some of you probably have seen in some of your own facilities, just a little bit of humor, I think, at the end of the presentation. And so I know people have been typing questions. We haven't had very many questions, so I guess you could unmute if you want to ask a question, or you could type a question. If not, we are done 4 minutes early.
Woohoo! Thank you, ladies, so much. So again, if you have any questions, you can come off mute with *6. And let me see.
Let us go ahead and share our email addresses because we neglected to put those in here. That way, if people have questions, they could just reach out to us.
Okay.
So, could you go back to the title slide by any chance, and that way they can see our names? That might make it easier. If that's hard to do, don't worry about it.
I think we're going to have
to. My email address is Karen Yates, common spelling Karen Yates YATES at MHD like Matt Henry David.com. And Debbie, you want to share yours?
Mine is Debbie, and you see Debbie spelled with a Y just to be different. Travis at texashealth.org.
So those are both pretty easy.
Yep.
Okay.
All right, we have a couple of questions. So you did mention doing drills. Do you have a tool that you use that you can share?
Actually, I don't. It's usually fairly informal. As I said, we've done them in the freestanding ERs. We've done them, as a transferring hospital. And it's just, obviously everybody has to know that it's a drill so that you don't have anybody getting all panicky and, overreacting or something. But it's really them just running through live, treating it just like they have a patient in the department, calling. Usually what I've done, for example, I've been at the transferring facility and just kind of, kept the times, basically. I'll usually be with the ED director or whomever, and okay, here's when they recognize, you hand them a STEMI EKG, let's say. Here's when they recognize it's a STEMI. Here's when they call for transfer. Here's when they call 911 or call for aeromedical or whatever their process is, just kind of a checklist. Now what, of course, can be skewed a little bit. We do include EMS in it, so, of course, EMS may happen to be there a whole lot more quickly than they normally would. So you have to obviously know that that's going to probably take longer. A helicopter probably isn't going to just walk through the door right at the same time that they call for one. And then we carry it through we've gone as far as flying a patient flying like a hospital employee to our facility and then kind of running through the same thing. On the other end, you're having to have somebody, from the time the phone call happens to say activate the cath lab, does it take 2 minutes before they activate that process in the emergency department? How does that work? but I don't have a formal checklist for it. You know, another thing that just came to mind that we actually did once that was really a lot of fun, we reached out to one of our local businesses, i.e. Chick-fil-A, and Chick-fil-A was very happy to do a drill that started in the community. And so we actually had a fake patient and the whole thing. It was almost kind of, we had multiple nurses all in plain clothes inside the Chick-fil-A trying to watch this whole thing, and it just turned out that there was a radiology tech that worked at one of our other hospitals, and he said later on, he says, I almost came up and asked why were all these ER nurses not getting up to help this poor man. But the whole idea was to get the attention of the public inside of Chick-fil-A about why it was so important to not drive. We had the patient and their family go through this whole loud discussion about would us drive to the hospital and, you know, all of that. We actually had a lot of fun with that, as did, I think, Chick-fil-A once some of their employees got over being terrified by what was happening. But it was actually a lot of fun. We enjoyed that. We videoed it with phones, and, you know, it was good. So, anyway.
Great. Well, we have a couple. I know we're right at one, so if anyone has to roll off, go ahead. But we have a couple more questions that I think we should tackle. One is asking, is there a Mission Lifeline program for referring centers? And yes, there is. So we'll attach that information in our follow-up email for everyone, the description of that, the criteria for that program. This is a great question that we had. It's, how would you suggest if a physician champion that you have is slacking or doesn't try anymore, how do you suggest asking him to roll off or maybe getting a new cardiologist? Have y'all had that come up in your work?
Well, it's actually kind of interesting. So I actually sort of recently had to address this, and the physician wasn't slacking. I mean, I think he was good, but my ED physician that was the chest pain medical director, and again, I said that was simply because he was the one I knew when I first came into the role. I clearly, I had very quickly after that identified who my cardiology champion was. Debbie knows him very well. He's the chair for our committee. He's one of Mission Lifeline's chairs. So I knew that the right thing to do was to migrate to him because he's a cardiologist and he's clearly bought into all of it. I did approach him about it at one point, and I said, you know, would you rather that we switch it from the ED physician to you? And it was interesting because his take was no, that he thought the ED physician actually maybe was able to look at things a little bit differently than a cardiologist would and kind of think outside the box. But anyway, last summer, we changed medical directors for the ED. So the chest pain medical director that I had was now working as a staff physician and no longer the medical director. So that seemed kind of the perfect opportunity because that was already changing. So I went back to him, and he said, oh, no, I'm fine, you know, take it and run with it. So just kind of through a natural occurrence, it moved over to being the cardiologist. But I think you have to do what's best for your program. So if you have a physician that's a low performer, that's part of your work group or your committee, if they have a medical director, go to the medical director and say, you know, I may need a different physician. If not, you may have to sit down and just talk with them one-on-one. The hospitalists have been the challenge for me because they tend to rotate through. You know, I'll get the same hospitalist for a couple meetings, and then I'll never see them again, and then it's a different hospitalist. So their medical director has actually just started attending the meetings in addition to, so that there's some consistency.
The other thing is if this person happens to be your medical director, then that kind of puts you in a real bind. I would recommend, like for me, I have co-medical directors, so I have a cardiologist and an ER physician. So then at least you have another physician that can help you try to champion some of that stuff.
Yeah, that's actually a great idea. I like that. Next question?
Well, I think that was it. Would anyone like to come off mute with *6? Now we're running behind. Running over a little. So if there's no other questions, we'll go ahead and end today's webinar. But thank you both so much for giving your time to us today and sharing some of your amazing best practices.
I just have a quick question.
Oh, yes, go ahead.
Do you recommend entering data into both Get With The Guidelines, CAD, and the NCDR We're trying to figure out which one we should go with. Or do you do both?
For us, what we do is we do NCDR, and through another program, they can push it over into Get With the Guidelines CAD.
Okay.
So that's what our hospitals have all done. So I think you just have to look at them and make a decision of what's best for your hospital.
Okay, perfect. Thank you.
Sure.
Great. Well, thank you all so much for your time today, and be on the lookout probably in about a few days for an email with how to claim your CE credits and information with the slides and documents also. Thank you all.
Thanks, everybody.
Thanks.